Okay, hello everyone. Welcome to Hot Seat. It's part 9. I hope you all are safe and enjoying these days at home. Today, I'm very lucky and very happy to have a very special friend and very special guest in our Hot Seat sessions. One of the leaders in the field of perio and implant, Marco Esposito, is here with us. And I'm sure that most of you are very interested in listening to amazing presentations. One of the most scientific persons I know, and I'm pretty sure if you are in the field of perio and implant, definitely it will be one of your references in different fields of practice when you're going to the literatures, you want to have a powerful conclusion. So again, I'm very happy to have Marco with us. Hello, Marco. Hope you're well. And
hello.
Accepted our invitation.
Fine. So far, so good.
Good.
Thank you for the invitation.
Welcome. I'm going to have a brief CV of Marco Esposito's curriculum vitae. Actually, it's many pages, so I just chose a very short CV from him to you guys, and then we will go to our hot seat session. Dr. Esposito is editor-in-chief of Clinical Trials in Dentistry, associate editor of the Cochrane Oral Health Group, president of the British Academy of Implant and Restorative Dentistry, academic advisor to the Diploma in Implant Dentistry at the Faculty of General Dental Practice in UK at the Royal College of Surgeons of England, director of the scientific company of the Digital Dentistry Society. Also, Marco Esposito graduated with honors in dentistry at the University of Pavia, Italy in the 90s, and was awarded a PhD in biomaterials from the Göteborg University in 1999. He created and directed the postgraduate dental specialties courses in dental implantology at the University of Manchester, United Kingdom from 2006 to 2011. He's a specialist in periodontics. He created and run the European Journal of Oral Implantology from 2007 to 2018, authored more than 300 publications in international peer-reviewed journal and book chapters, and gave more than 600 lectures and courses nationally and internationally. I'm so proud and honored to have Marco Esposito at Hot Seat session, and the topic that he will present today, as you can see, is to believe or not to believe. That's the question. Marco, we are ready for your valuable presentation.
Thank you. Thank you for the kind presentation. And I choose this title, which seems to be a little bit odd, because I think it's very relevant. It's going to be a little bit theoretical presentation at the beginning, but it doesn't mean that if it's theoretical, it's less important. And then I will finalize it with a practical example about the efficacy of antibiotic therapy at implant placement. So I will go directly to the point, and I will say that one of the most important questions is if we can trust all the information that are overwhelming us. Especially today that we are locked in at home and we have got plenty of time, we are listening to more courses, information, social posts, and so on. And the question is, are we able to discriminate them, the real one from the fake one? And the fake news are really easily spread through the social media, and not only through the social media, they can be spread in many different ways. So at the end, the question, which also in dentistry is important, is to believe or not to believe to what we are told. And I would say that I could start with my answer is, you should start not to believing, and then you should activate your brain. So I think that you need to do always a critical reasoning when you hear information. And then if you think after this critical reasoning that this information can be valid, and I will try to help you to see how you can criticize an information to understand whether it could be valid or not, then you could decide to apply to your clinical practice. So one of the most important things in dentistry and in medicine is where to find clinical reliable information. We have to treat our patient. We have to take decision. So what we base our decision? And there are many ways we can get information. Recently, more and more popular as this one is to reading or listening to social media. Usually, before social media, we were going to ask some people that had more experience. The problem with this is that depending on to whom you ask and depending on the experience this guy has, or then we can have different answers. And this answer can be totally different from each other. So we can have a patient with a given problem and we can have so different answer that we are really in difficulties to understand how to choose which could be the best way to treat. And obviously, these answers are opinion bias, are leading to opinion bias practice. Obviously, if we don't have evidence, we need to treat the patient anyhow. That is outside of any doubt. But we have to be at least aware that we are using opinions, and sometimes we don't have science to back up our decision. So what I'm going to try to do is to see how science can back up your decision, and I wish you to try to implement these procedures sometimes. You can read a book, but the book has the same limitation. I mean, has been written by somebody with a certain given experience, and nobody can actually tell whether this is true or not. So a book is, before we are talking about oral opinions, and now we are talking about written opinions. The thing that you should do is to search electronic database for articles. You can go on PubMed, you can go on the Cochrane Library, that by the way now is free access. They decided kindly to have a free access during this period because people have the time to read and people is seeking for information. And so you need to be able to read, and not only read, but interpret this information. Interpret it doesn't mean that you need to read the conclusion. You should never read the conclusion. What you should read is the material methods, and if you trust the material methods, the results, and then you make their own conclusion. So to make to use a sentence which an Italian philosopher that died a few years ago said, I think his last sentence probably has become one of the most famous. The guy is called Umberto Eco. I will quote as it is, and it is about social media. Social media gives legions of idiots the right to speak. When they once only spoke at bar and after a glass of wine, without harming the community. But now they have the same right to speak as a Nobel Prize winner. It's the invasion of idiots. So the point is that everybody can say things today, and there are very few people that know how things are, but we have difficulties to understand who is telling an important or real things and who is just taking fake news. And this is going to be one of the biggest problems we are going to face over the next year. So going back, what we should do is evidence-based practice, which is the integration of the best clinical research evidence with our clinical expertise, and keeping in mind that we have to treat a patient and we have to respect his wish and his value. So how the process works? Well, you start to ask a good question, an intelligent question. If you ask for an intelligent question, you may even get an intelligent answer. But if you ask for a stupid question, you definitely get a stupid answer. Then we need to find the evidence. So we have to find the literature. We should be able to read it and appraise it. And at the end of this process, we should act. Because if you are not willing to act, then it's stupid to waste our time to read and try to update. We only update if you are willing to change our way of working, if we found something that we believe or has been shown to be more effective, or what are we doing. So why we need evidence-based practice? Well, because obviously clinical information should be based on updated and reliable evidence and not on personal opinions. What we do is opinion bias practice. And to tell you some example of history, now you will laugh at me and you will laugh at this poor guy of the past. And but keep in mind that in 100 years time, they will laugh at us in the same way. You probably don't read German, and this is Doramad, is a toothpaste. Is actually, you can read here, a radioactive Zahncreme. Zahncreme means toothpaste in German. Okay, so this was sold in the between the 20s and the end of World War II. And why they were selling a radioactive toothpaste? Actually, it was even expensive at the time to buy it. Okay, so this was slightly radioactive, and because it contains small amounts of thorium, okay, that is a natural radioactive element. Why? Because they claimed they had antibacterial action, which I do believe, and then it was strengthening the defense of teeth and gums. I'm not really sure about that. Anyhow, there was a belief that the radiation was making the body stronger. And now we laugh because we know very well that radiation are not making our body stronger, but on the contrary, they are bringing us to have cancer. But this was the evidence that was believed, not really the evidence because there was no evidence, but this was considered to be the evidence, okay? And what's happened is, this is a funny story, but it's also true, that when German occupied France in World War II, they basically stole all the thorium. And this actually put the Americans and the British in an alarm because they thought they were going to use thorium to refine uranium in order to make the atomic bomb. So what they did, they make an espionage mission called Alsos missions. And the idea was to get, at the end of the war, all the German scientists working on the nuclear project and try to understand how far they were in this process. And what they realized that this radioactive thorium was not stored to make the atomic bomb, but the idea was to mass produce radioactive toothpaste in the post-war. So is that enough? No, really, because as they did the toothpaste, and there are different types of radioactive toothpaste, there were also some made in US, of course. There is the lipstick with radioactive properties, and then they did a facial power, and then they did hand cleaners. We are always talking about between 9010 to 9050, so even a few years after the war. And then they made cigarettes. So you don't have only nicotine. In addition, you have also some radioactive elements included in the package. And then they did some pastilles. Also biscuits for kids. If you want to have your kids stronger, why not giving some radioactive biscuits or some radioactive chocolate? This was sold until 36. And to protect the little kids even better, we could even provide them with wool, with clothes made of radioactive wool. And then we had the muds to make female skin more beautiful. And you can imagine if you do a lot of application of this mud, which could have been the problem after a few years, you can imagine how many skin cancer these poor ladies could have developed. And of course, we don't forget about the eyes. We don't forget about something else because they also did the suppositories. And finally, they also did the condoms that were even glowing. So in the night, you can see what you should see and don't get lost. This is another publicity for the radioactive water. This was used in US. And it was advertised as a medicine to treat arthritis, rheumatism, mental illness, stomach cancer, and even impotence. So by drinking this magic water, our ancestors had the chance to solve all the problems. And you understand that now we still have a lot of problems, right? And we have the story, this is true story of an American guy which drank more than 1,400 of this bottle. And obviously after some years, he became very ill and died because of multiple cancer in the mouth. He had several operations. You can imagine what miserable life the guy had. And this is not all. I mean, this is another one. I mean, all these objects now are looked by collectors, because they're trying to find them, but you have to be careful because actually they're radioactive, so they have to be placed possibly in some situation where they could not harm any longer. And look at how scientific is the booklet. We are talking about now we are in the 30s. A new scientific principle for supplying the human body with remarkable energy and power of genuine radium in a pure, harmless, and wholesome form. Easy to take and economical. So this, we can laugh at them today, and I assure you they will laugh at us in 50, 100 years. So let's try to be a little bit smarter. What's happening today? Well, you know, in Italy, in Iran, in the rest of the world, we have a huge problem with the COVID-19 disease. And one of the discussion is how to test patients for the presence of immunoglobulin against them. Why this could be important? Well, it is very important because if you develop a resistance, then you have no risk or a very minor risk, and then you can go back to a normal life. But the point is that many companies are trying to sell rapid detection kits because you have to mass screen population of hundreds of millions of people, otherwise it's not going to work. And what's happened is that I was starting to do, I wanted to do some clinical research in the field because now dentistry is not of big interest to anybody, to be honest. And I was negotiating with a nice American company, which I told them, well, before going to a mass screening, we should do some testing to see whether these tests are valid. And they tell us that the people that have taken the disease are really considered like that. And then they said, there's no need to do this because we have already a Chinese study. And they sent me the Chinese study. And what I did, I read it. And when I read the study, I was horrified. I was wondering which journal could have been published this type of study. It was no information provided at all, so you cannot really make any kind of judgment. And obviously, if you cannot judge how the information were created, maybe you don't have to trust what is written over there. And nowadays, everybody is discussing which is the best treatment for the COVID. And there are so many new articles published in hurry in many, even prestigious journals. And many of them now are being retracted because after just a few more time is gone, after some rethinking, they realized that the quality or this article is actually very poor and they could be risky because they could put the life of people in danger. So we are living today a situation where we are delivering treatment. We don't know if they are efficient or not. And if we don't even try to test them in the proper way, we will never know it. So we have the chance to apply science in the correct way. And that is important to be done. So what is the main problem? The problem, I think, is the dentist always focus on how to do and not on what to do. All the seminar you've been having over you have been bombarded by seminar over these days, and they always tell you, you should do this, you should do that. They give you all the little tricks, but nobody tell you what to do in the sense that nobody tell you if that treatment is actually the best one, if it is effective, or it could be even causing problems. And that is where we lack. And that, I think, dentists should become more critical, not only on how to do, that is important, but first you know what to do. So how to do is the point. Obviously, we would like to have, like in, you remember in university that you had a step-by-step instruction manual, you believe whatever the teacher were telling you, and then you went in the private, in your practice, and you realized that the situation is completely different. So you have to consider now what to do and not only how to do it. So why we need reliable clinical research? Because we need to take the right decisions, okay? And we need some help. Which are the problems? Well, one problem that I want to discuss later at the end of the presentation is whether I should give antibiotics at the implant placement or not. Because if they are effective, okay, I give them, but if they are not effective, of course, I can have some side effects, and some of the side effects, even if rare, can kill the patients. So then we shouldn't do it, but we need to know whether they work or not. And we have many other cases that I'm not going to discuss here, but are all topic of my, I would say, big research line. Now we have a lot of publication with follow-up of 10 and even more, or even longer, 10 years and even longer. For instance, in case of jaw atrophy, should I use short implants or augment? Or should I use autogenous bone or a bone substitute? Or is keratinized mucosa, when is keratinized mucosa lacking, should it be recreated or not? So all questions that people believe to have the answer sometimes, but I'm not really sure that everybody has the right answer. So we have to be a little bit critical on these questions. And remember that you cannot take an informed decision if you don't have information. But not all this information are created equal, meaning that there are some information that are reliable, some information which are less reliable or not reliable at all. So how do we discriminate between reliable and poor clinical research? Well, by doing the critical appraisal. So we need to read the paper, understand what they write. So this is the process of assessing and interpreting evidence by using a systemic consideration of its internal validity and relevance. So I will just give a very brief explanation of what is internal validity and relevance, hoping that you can follow me. They are very simple and basic concepts. And then I will provide you which are some simplified information. I will be very, very simple and not go into details, okay? So don't get scared. What is internal validity? Well, the degree to which the results of the study is likely to approximate the truth. In other words, is how well the study is done. If I perform a study in the proper way, most likely I'm very close to the truth. If I am not doing the study correctly, maybe I miss the truth and I come to some fake conclusion. And this fake conclusion can cause big problems. And then there is the concept of external validity. This conclusion may apply only to a certain group of patients. For instance, the external validity is the degree to which results of a study hold true in another setting. If I do a study on the lethality of COVID-19 and I took a cohort of university students or high school students, I will say that, well, the mortality is less than 1,000%. But if I change population and I take people that are very old with comorbidities or which are in some hospice, then I will find a morbidity maybe is going to be 20%. So the validity of a study applies to a certain population. So what you would like to have is a study that is internal valid, so well done, and can be applied to your own population. So these are two aspects that you always need to evaluate. So the question is, but if I read a journal that has been published on a good journal, why is necessary to do a critical appraisal? Well, because we have the issue of bias, which is a sort of mistake which will alter the results of the study. And we need to be sure that it's not there, okay? And to do this is not easy. I mean, a critical appraisal is a very difficult process because there are no absolute rules. Now, I would like to invite you to think and to reflect about clinical research, in this case in dentistry, but applies also to medicine, and why we do clinical research. Unfortunately, there are some not very good reasons to do it, and obviously there is also some good reason. Well, one of the reasons to do clinical research is if you are working in university, is the only way you can have in some countries an academic promotion, okay? If you are not in the university, you may want to show your colleague that you are very good. So we are very good, you come to me, you do the course with me because I'm teaching you things that nobody else can do. Or I do clinical research because I want to show that the product that I sell is very good. So companies or dentists that are working with companies are somewhat interpreting in a certain way the results, let's say in a more positive way, because they are biased by this fact. And even the research that can be sponsored by the National Health Service can be wrong, in a sense that what they have been doing now with National Health Service, cutting funds, cutting money. This has happened in Europe, and I guess maybe in other parts of the world, okay? And so they sponsor research that could show that cutting was not necessarily going to be a problem. So to find the cheapest treatment. But sometimes by doing this, you end up to be in the situation as we are right now, where our most of our cope with the, I would say, unexpected situation, but it's not unexpected. I mean, if you know history, a bit of history, because history is very important, you know that is every certain number of years, there's been a different type of pestilence, or there has been some big disease. The last very big one was there were some a few years ago in the 60s, but the biggest one we had that we still have some memory was the Spanish flu, which was not Spanish, but it was called Spanish flu. And it was at the end of World War I. And it caused something between 20 and 50 million of deaths. So something very big if compared with what we have now. So we don't have to feel so miserable, because in the past it has been much worse than now. So we are the lucky one, to be honest. But the real reason to do research is to solve clinical problems in order to help patients. A good reason is to find a good treatment or a vaccination to treat the COVID-19 disease. That are good reasons to do research, not to get an academic promotion or to show how good I am to my colleague. So what is bias? I will give you a definition, an official definition, but then I will also explain you some example very, very briefly so you understand what I'm talking about. I read now, a systematic error or deviation in the results occur in a study determining the difference between the obtained results and the results we should have obtained in the absence of bias. So if we have bias in the study, the results change. And if the results change, we don't get the truth. And we can be misled. How many types of bias? There are more than 20 bias, but we don't need to mention them all. There is the publication bias, that is biased toward positive results. Science is biased toward positive results. If the treatment works or appears to work, I publish the result. If the treatment does not work or appears not to work, I don't publish the results. So what we see is the positive effect, not the negative one. So we believe things are working better than what are in reality. Selection bias, if I'm comparing two groups that are not similar, if I'm comparing, let's say, young people with old people with a lot of disease and healthy young people, of course, there is bias there. If I am exposing our patient to additional treatment, additional factors apart from the intervention I want to evaluate, that is called performance bias. We have attrition bias when we are losing patients for some reason and we don't know why we are losing them. So the patient die or they get ill or whatever, or are excluded because they have problems. I see studies that if a patient has a problem, they excluded it. And then if you remove all the problem, you understand better than me that there is no problem and the treatment is very good, but you also understand that it's not the reality. Then it's also how we measure things, We are dentists, we use a periodontal probe, but we use a radiograph, and you can understand better than me that depending on the force I use the periodontal probe, or I depend how I read the radiograph, I can have completely different results. The commercial bias we mentioned before, so I don't have to go deeper there, but I would like to emphasize the so-called confirmation or confirmatory or my-side bias. That is the tendency to notice and to look for what is in agreement with us. So whatever agrees what I believe is good, and what else that is not agreeing with what I think, but is less, we consider it to be not important, we neglect it, or we undervalue it. And that is that we don't see the reality because we are convinced that what we are thinking is the correct way. And this is a very big problem with the humanity, and I think we are going to have this problem forever. Now, depending on the questions that you want to answer, there are different study design answering these questions. In medicine and dentistry, you can have different questions like diagnosis, cause of a disease, prognosis, how to treat, risk benefits, cost effectiveness. So each of these questions has a different study design to be used, okay? This is not an opinion, it's science, okay? So I'm not going to go through this, but very rapidly, if I want to evaluate which is the best therapy, I have to do a proper randomized controlled trials. We have other situations, for instance, if I want to do a study on prognosis, what is going to happen on my patients, I have to run, not a randomized study, but I have to run a cohort study, okay? So now, how we evaluate which is the most effective therapy. This is really what is important for us. Diagnosis in dentistry, at least in oral implantology where I work, is quite simple. You see how much bone there is, you see the anatomy of the bone, you know the anamnesis of the patient, and if everything fits, you can do it. But if you ask you which is the best therapy, should I augment, should I use short implants, if augment, what I'm going to use, then we have a lot of questions that are still unanswered. So the first things that we are going to evaluate, we know therapy, what it means. That if I'm going to discuss about antibiotics prophylaxis in implantology, the first comparison I'm going to make is I give antibiotics and I give no antibiotics or a placebo to my population and see whether antibiotics determine less implant failure and complication. Or we can be in another situation where we can, I know, for instance, antibiotics are effective, and then I'm going to provide the antibiotics I believe to be the most effective, the gold standard, amoxicillin, and I compare with some other antibiotics to see if they are equivalent or not, okay? So if you want to evaluate effectiveness, you need to have only comparative studies, where the new therapy is tested in a group of patients, and in the other group receive no therapy or a different therapy. And it is very important that is done in humans. Many run studies in dogs and rats, but I wonder if you've seen a dog smoking or brushing his own teeth. So you cannot extrapolate data from a dog to the human unless the human looks like a dog. So in a situation like this, maybe you can do that, but in general, you cannot do that. So this is a controlled clinical trial that is a study that is not existing, is only existing in dentistry, but it shouldn't exist, because what we want to have is not to have a controlled clinical trial, but something else. So what is the main limit of this control study? Is that we can select the two groups in an impartial way. So I will show you now how the study was run about an Italian dentist that wanted to evaluate efficacy, masticatory efficacy in females. So he created two groups like this, and you can see by yourself that the two groups are not actually comparable at baseline. They are quite different. So how you avoid this problem? Well, first of all, you don't ask an Italian dentist to do the selection of the group. And what you should do, you should by random select the patient. You can toss a coin. There are better ways than tossing a coin, of course, more scientific and more valid. But anyhow, tossing a coin is a randomization process. So by doing randomization, we can balance the groups, and we can create two groups that are big enough and balanced so that we know that they have similar characteristics. And then in one group, we can give a treatment, and the other, we are going to give a control or another type of treatment. And then we can really have reliable results. And this study is called randomized controlled trials. So these are the only study that can be used to understand which is the most effective interventions. There is a hierarchy for this. I don't want to go too much in details. So at the top, there is the randomized controlled trials, meaning that you can have a systematic review of randomized trials. And if you don't have these trials, if you don't have a systematic review, and if you don't have these trials, you have to go to a lower level. So we end up in having controlled trials, which theoretically should not even exist, or control observational studies. So the level of evidence is lower, okay? And if you go below, we have the so-called observational study without control. They say so-called case series, okay? You have not a control. You treated a few patients. What kind of information you can get out of it? And at the end, what dentists read, the case reports, the expert opinion, and the consensus conference. And at the bottom of this, we have the social media post, okay? So this is the hierarchy of evidence. So now, if you are even reading and choosing the correct study design, doesn't mean that is a good study, because you can do a good randomized trial or a bad one, okay? There is a huge variability on how to run a study, okay? And then it is your task to be able to evaluate the quality and identify those potential flaws which may bias completely the results. So how to do that? Well, you have to see if the number of patients included in the study is enough. You have to check whether randomization is done in a proper way. You have to see whether patients, outcome assessor, providers, statisticians are blinded or not, if they could be blinded. And then we need to know what's happened to our dropouts, why they drop out, why patients were withdrew, why there is missing data, and all this kind of information. So this is not going to be the topic of today, just to tell you that there is. And another aspect that we should evaluate are outcomes. Outcome is how we evaluate parameter of success, how we evaluate success. And we have primary and secondary. Primary are those, or true outcome measure, are those that have a tangible influence on patient life. What is in dentistry? Functional prosthesis. I mean, you have a patient with no teeth, he come to get implants, and what we evaluate? if the prosthesis is in function, if there is no complication, no pain, if the aesthetic is acceptable. So patient satisfaction, aesthetics, lack of complication, and function. These we should evaluate. If we are talking about different things, of course, we have different primary outcome measure. What is the primary outcome measure, for instance, for treatment of COVID-19? Survival, either you die or not. Or second is, if you survive, in which condition do you survive? Are you going back to how you were before, or you're going to remain handicapped for the rest of your life? So these are the major parameter we should be used in this type of studies. Obviously, we have secondary or surrogate or predictive outcome measures that those are those which may predict the primary outcome measure. I say may predict because prediction is very difficult, okay? You remember a few months ago, they were predicting economy in Italy will, the PIL will increase, PIL will increase, il prodotto internal lord, I don't know how to say in English, will increase of 0.2%, in Germany will increase of 1.5, and so on. All these predictions completely wrong. They miss it completely. And the prediction they are doing today are going to be found to be wrong in a short time. So prediction, you have to be careful, okay? Anyhow, we tried with that. And what we use to predict in dentistry? Well, we evaluate if we have plaque, if the pockets are bleeding, if the depth of the pockets is increasing, if you have marginal bone levels. But these are a prediction which could be right or could be wrong. So we have to be careful about this. So where we can easily access scientific evidence? Well, the best paper to read is an update review of the literature, but not a narrative reviews that tells you the story that they want, because they don't follow the scientific principle. They are not structured in a systematic way. Okay, so I'm not interested to hear the opinions of the stories of that. What I need is a systematic review. That is a review that employs explicit and rigorous method to identify, critically appraise, and synthesize relevant research in order to limit bias and to reach evidence-based conclusion. If we are lucky, and we are going to do it now, because I'm going to make an example now, we're going also to have a meta-analysis, which is a technique which is used in a systematic review to allow combination of quantitative data in order to estimate with more precision what is going to happen, okay? So what we need to read is a systematic review. I agree. The systematic review is the most boring paper to read, and I will tell you more, it's the most boring paper to write, because it's really, you need a big competence to do that. On the other hand, it's the most useful one. While the case report, that is very beautiful to see, and you applaud to the great success of the guy, doesn't tell you anything, because this could have been right, and next one can be wrong, and you just publish the one that goes right, or vice versa, if you don't like a procedure. So when this systematic review are very useful, when we have results that are of different studies that are totally in disagreement. So we need to understand why, or when we have many studies that are too small. So the sample size, the individual sample size are too small to find a statistical significance. And that is the case that I'm going to present you soon. So how should be systematic review? Well, if dealing with therapies or prevention, well, it should be based on randomized trial, because they are the study that, if done properly, are the one providing the most reliable information. Studies which are not randomized tend to overestimate intervention effects, so they are less reliable. Now, people think that to do a systematic review is easy. So everybody asks me, I want to do a systematic review. It's not easy at all. You need to be very professional, and you need to be much more professional than to run a trial. You need to have an experience of many trials to be done, and then you can start to consider, because you need to have a much bigger, profound knowledge of scientific methodology than not to run a simple studies. So who makes systematic review? Anybody can do it, but there are some organizations, among which the Cochrane collaboration, that are actually doing only that in a professional way, and they are trying to help people to take good information, a good decision about health. Obviously, they are going to evaluate the benefit and the risk of healthcare intervention, because there is always a balance between benefit and risk. Now, I want to summarize, and then I will make you My example of what we said so far is that if you going to read some paper, you should choose the right paper. So you should evaluate if the paper that you're reading is the proper study design to answer your question. If you are interested to know which is the most effective therapy, then you should look for a systematic review of randomized controlled trials or randomized controlled trials. If these papers are not available, then you have to go to a lower level of evidence, an inferior level, like core studies. But you have to be very cautious when interpreting the data. And whichever level of evidence you are going to consider, validity and clinical utility of these studies has to be critically evaluated by you. So read the paper very properly, evaluate the main flaws which can alter the results in a significant way, and then you decide whether you can transfer the results of this paper to your population of interest. Maybe you decide, okay, the paper is not good enough, I don't change my way of working, or my God, this is really convincing me, maybe I should do it a different way. So use your head, read all the papers carefully, and do not trust what is written in the conclusion alone. So don't read the conclusion alone. Actually, you can only read the conclusion after you make your own conclusion. So I'm going to terminate before doing the example with this final slide. What we need, we don't need more research, it's too much. There is too much research around, nobody's reading it. So we need better research, we need balanced information, benefit and harms. And I would like to remind the sentence of Altman, which was a statistician and said this actually 30 years ago. We need less research, we need better research, and we need research done for the right reason. Fine, so how can I help in this process? Well, I try to create my second journal, and this journal is called Clinical Trials in Dentistry, where you can find applied exactly what I've been writing so far. So I am the editor-in-chief of this journal. I am helped by Dr. Michele Nieri and Jacopo Buti, which are very competent, open-minded researchers and clinicians. This is done with EDRA, that is an Italian publishing house based in Milan, but the journal is in English and is open to all trials in the field of dentistry. For the time being, the majority are actually in implantology because it's one of the lines that has been stimulating maybe more research, but I hope that very soon we are going to have authors also sending out papers about endodontics, prosthodontics. Prosthodontics, we really need papers about that because there is very little science in prosthodontics, orthodontics, and so on. Now, if you are interested to know more, the first two issues are available, and you can look, link for the free issue, so you can download the full issue, you can read it by yourself. You can find this on my Facebook page, or you just write me an email. I will give you now my email address. And for those that have a good trials, it doesn't have to be positive. It has to be designed properly. Then I don't care if the treatment is effective or not, because if it's not effective, we need to know. Because if it's not effective, then we should not deliver. And we have to publish this information, otherwise we don't know it. So just feel free to submit it. Now, example of a clinical question. My question of today is antibiotic prophylaxis and implant placement effective? So shall I give or not antibiotics to patients that are going to receive simple implants? I'm not discussing now complex bone augmentation procedure, because I think there is sufficient evidence to say that yes, it is needed. But let's talk about normal implant surgeries. 1, 2, 3, 4, 5 implants placed without augmentation. Now, the first osseointegrated patients treated with osseointegrated dental implants was treated in 1965, more than 50 years ago. And which was the protocol at the time, has been used for more than 30 years, at least in Sweden. To be honest, I don't know if they're using the same one, but until the 90s, I was there, I can tell you they were using that. Which was the protocol? 2 grams of penicillin B 1 hour before, plus 2 grams twice a day for 10 days. It's 10 days of antibiotics. It's actually a big dosage. But other people in other country, in other place, what they were saying, there is no need of antibiotics. There is no difference if you give them or not. So who is right? Now, let's have a look about which could be the adverse events by giving antibiotics. They can be minor ones. You can have diarrhea, erythema multiforme, urticaria, vaginitis, etc. But you can end up in life-threatening allergen reaction. You could get an anaphylactic shock and then you may die. This is quite severe consequences. There is also the risk of selecting antibiotic-resistant bacteria, but this is if you give it for weeks, okay? If you give the same antibiotic for weeks, you have this risk. But if you give it once only, this risk is zero. So we have here a Cochrane systematic reviews published a few years ago. Ideally, it should be updated, and there is not so much more studies after that. So the evidence is until 2013. And the clinical question were, is antibiotic prophylaxis effective? Which is the most effective antibiotics? Which is the most effective dose? When should I give antibiotics? Before, after surgery? And for how long? Is enough before, or should I go on for 1 week or 10 days or 2 days? So all questions, what is the difference between a systematic review and a trial, randomized trial? Is a randomized trial, so you can maybe maximum answer 2 questions, no more than that. While in a systematic review, you can combine multiple questions, so that is an advantage. And in total, at the time, in 2013, we have 6 randomized trials to answer which is the most effective antibiotic prophylaxis, if it is effective or not. But regarding the other topic, we had 0 studies. Not a single study comparing which is the best antibiotic. And only 1 very small study, so small that cannot provide any kind of valuable information, telling for how long you should provide antibiotics. So it's a little bit disappointing. I will just give you an idea of this study design. And then, if possible, I'm going to do a meta-analysis. I show you some data of the meta-analysis, and then we go to the conclusion, and we know whether antibiotic prophylaxis is working or not. So we identified in total 7 studies. 1 had to be excluded because the follow-up was a bit too short, only 2 months. Most of the studies, 3 were done in Italy. The rest was done in Spain, Belgium, and Ireland. So they were all done in Europe. So the business of randomized trials seems to be more European than not, I would say, international, at least in dentistry. In total, we have data from 1,162 patients. That is not a very big number, but it's better than nothing. And the first study published, the first patient treated in 1965. And the first published study is in 2008, more than 40 years before having the first study. My God, if science is going on at this speed, I mean, I don't know what is going to happen. We are going to know the best treatment for coronavirus in 40 years. So how was the study? Was 2 grams of amoxicillin versus placebo given 1 hour before in a certain number of patients, 216. Same year, another study similar, a little less, it was 1 gram amoxicillin before and then 500 4 times a day for 2 days versus no antibiotics, less patients, only 80. Another study, again, very similar to the first one. The only difference was less patients and focusing only on single implants. Actually, very strange inclusion criteria because they are focusing on the patient less likely to have a problem, only the one that have a medium hardness of bone, while we should know what's happening in hard bone, soft bone, and whatever. Anyhow, it was done like this. Then I did a second study myself that was a duplicate to the first one because I didn't find it. I realized that the 316 patients were not enough, and I wanted to do another study with a bigger number of patients, so we achieved more than 800 now. And I had to do it as similar as possible to the first one so that it was possible to combine the data. Then we have the study I told you that tested several timing, but you see there are 4 timing with only 25 patients per group, which is too small number. And finally, a study done in Ireland where they are using the British way in the sense that they are giving 3 grams of amoxicillin instead of 2 versus a placebo 1 hour before treatment, and that's it. So this is now a meta-analysis. I will help you to read it, and then once you have learned to read this, it will be much easier to understand. I'm talking how many implants fails when I give or not give antibiotics. So each study is here. You see the authors of the study. You can see here a horizontal line. This line corresponds to the confidence interval of the study. The wider is the confidence interval, the less reliable of the study. And one of the parameters which make this wider is the number of patients. The more patients you have, the more precise is the information, and the smaller is the confidence interval. So if I take this study that has the smallest confidence intervals, and I see the number of patients, you can see immediately this is the number of patients in one group and the other number of patients in the other group. You can see that this study has the biggest number of patients, okay? Then we have a vertical line. This vertical line is called line of no effect. It means that if the horizontal line crosses the vertical line, there is no effect. What it means? There is no statistically significant difference. So if we look study by study, all the study done, no one show a difference. There was no difference in implant failures if I give or not an antibiotic. But if I combine all the data, and by combining data, I increase the sample size and I get more precise information, what I can see is a much smaller confidence interval, of course, because we have much more data, and you can see that it's not crossing the line. What this means, that antibiotic prophylaxis is effective, I repeat, is effective in reducing number of implant failures. So look at the picture if you don't want to look at the number. The picture shows that there is a difference, a statistically significant difference. You know that is for implant failures, and you know that is favoring antibiotics. You can do things in other ways. Here you have the p-value that is quite high. Okay, you can also do it in other ways, very primitive, but it is logical to understand. I give no antibiotics to 558 patients, and 32 patients have at least an implant failure. While if I give antibiotics to 604 patients, only 9 patients get an implant failure. That is more than 3 times less. That's not really a proper way to do the analysis, but is really easy to understand even for a small kid. Now, a way more sophisticated to show this data is to present the NNT, number needed to treat. So how many patients I should deliver antibiotics to have 1 patient not having an implant failure? And that is 25. So if I give antibiotics, prophylactic antibiotics to 25 patients, patient number 25, who should have had an implant failure, actually has not an implant failure. Then you can evaluate whether this is something good or not, because I'm not telling you what you should do, I'm just providing you the data, and then you decide. Because on the other hand, you have the risk that if you treat a lot of patients, maybe you have the unlucky one that will get an anaphylactic shock. So you have to balance these 2 things. Obviously, the chance to get an anaphylactic shock is the same as to win the lottery, okay? Some people is very lucky and some people is very unlucky. I present also the data on prosthetic failures, and then I will finish. Prosthetic failures, I mean prostheses that could not be placed because the implant failed before, or they failed after I placed the implants. I mean, I put them on the implants failed. This is really what matters to the patient, because if you lose only 1 implant and then you put the prosthesis on the patient, nothing changed for the patient in reality. But now, if you lose the prosthesis, I mean, you fail completely the treatment. And you can see there are less studies because 1 study is not reporting that information. And here it's quite a miracle. We have a statistical significance that is borderline. It is 0.05. That is the number, the only number that we have that says it is and it is not. It's the borderline, you know. But by the way, my interpretation is that clearly we have more implant prosthesis failure when we are going to do when we don't deliver a prophylactic antibiotics. I just give you a little information about adverse events. Now we give a little dosage for very short or almost no follow-up, so it's very, very little. How many adverse events? Well, reported only 2, 1 in each group, which means no difference at all between the 2 groups. They are very, very, very minor. So 1 was itching for 1 day, and the other patient had some diarrhea. And that's it on over 100 and 1,000 patients. So if we deliver small dosage of antibiotics, the likelihood to have this common side effect is not so common. What you cannot say anything, obviously that could be underestimated because we ask it, but maybe the patient didn't report it. I cannot, there is no way we can know about that. But remember that we can not find a rare adverse event like an anaphylactic shock, because this can happen maybe once in a million of patients. And if you don't treat a few millions of patients, we can see how often this can happen. So this, even if we don't find it here, can always happen. So keep it in mind. Now I'll conclude very fast. Conclusion is that we have more prosthetic and implant failures if we don't give antibiotics, okay? We know that giving the antibiotics at the dosage I presented you before, we don't have relevant adverse events. If I want to quantify, I could say that if you give antibiotic to 25 patients, we can avoid 1 patient to have an implant failure. And now this is your own decision, but your own decision should be based on that study. I personally would consider that a single administration 2 grams of amoxicillin before implant placement could be sensible, so could be done. But if somebody else tells me, no, I don't want to get the risk, even if it's very low, to have an anaphylactic shock, fine, don't give it. But at least you have the data to which you base the decision. You can inform the patient can tell you, I don't want to get the risk, and that's it, no problem. I don't tell you what you should do, I just help you to decide yourself. Now, the problem is that we have insufficient evidence to tell you which is the best antibiotic, which is the best dosage, for when we should give it and for how long. All this information are still lacking. We have a lot of opinions that can be right, that can be wrong, but these are opinions, so we don't know. Now, I would like to end with this funny sentence of this little dog. We call him Snoopy. And Snoopy is praying God if he could uninstall 2020 and install it again, because current year 2020 actually has a bad virus. So with this hope that all the problem will soon be over, I would like to finish. I will thank you for your attention. I think maybe we have some time to do some online question, I don't know. Anyhow, there is my mail, and if you have any question, I will try to answer. I will try to give very condensed answer, meaning yes, no, I don't know, but I tend to answer all the time. Thank you really a lot for your attention.
Thank you so much, Marco. Like always, I personally enjoy your presentations every time I listen to you, because truly scientific. And I have to say, especially the first half of your presentation, really important for all people willing to do research, because that was the basic that we should know about doing every type of research. And as you said, even I'm at the university, and when I see students want to have a thesis or do some research, usually first they go for the conclusions, and that's the real problem. And it's very important for them to go to the method material, and as you said, to be able to be evaluate enough to decide whether this type of method and material is correct or not to interpret, and it's very, very crucial. And about the antibiotics, me personally, I usually, if I do simple implants, I don't prescribe antibiotics. In my experience, for simple implants, when I do bone grafting, because I apply some materials from outside in the body, so I prefer to prescribe antibiotics. But for simple implants, usually if my patient does not have any systemic conditions, or for example, older patient, or in non-procedures, or in, for example, diabetic patients, even with good control, I prefer to prescribe antibiotics. But in normal implant placement, no. But what you presented, that according to the literature available, the like prophylactic antibiotic prescription showed better results according to the systematic reviews. But what I considered was that in those studies, in some studies, they prescribe like 1 gram, in some they prescribe 2 grams pre-op. In one study, they prescribe 3 grams. So systematic, we know that antibiotic prophylaxis is better. But about the dosage, as you mentioned also, that we don't know. But if you want to recommend something, the 2 grams, as you said, is recommended, right? Is it based on the systematic review or based on the conclusions for different studies?
Well, most of the studies have you using the 2 grams and only with a preoperative. And you can do a smaller systematic review only using them, and you come with the same conclusion. So the difference in England, they use 3 grams historically. Okay, and you know, British are these were Irish, but the British do the same. British are traditionalists, and before they change the tradition, it will take some time. Where this come from? This come from the treatment of, for the prevention, not the treatment, of endocarditis. Yes. You know that dentists are considered to be at risk of causing endocarditis in patients because we have a lot of bacteria in the mouth that goes in the blood, and then they can stop on the valves. So there has been many different guidelines which should be evidence-based. Actually, the evidence is very poor, and the guidelines completely changed over the years. What they found out, anyhow, was that by giving 3 grams and by giving 2 grams, when you do the blood samples, the concentration of the antibiotics in the blood, that is the active phase, okay, was the same. So by giving more antibiotics orally, you had not an increase of antibiotics in the blood. So the idea was why you should increase the toxicity of a product by giving 3 grams, and it's not better to give only 2 grams. So that's the reason why they use that. So most of the study, another thing that you can see, I don't know if you can see the screen now. I mean, I don't know if you can see my presentation. I put it back, and I would like to show you something as well. Almost all the studies are overlapping to each other, and they are all going to the same direction. So you can see that all the studies are actually having similar results. The only exception was the study, since you asked me a question, then I have to give you a more detailed answer. There was the study of Radithor. Radithor did what? Did a study only on single implants, placed only in medium bone quality, and they find no difference. But there is a very big limitation in the study, because you don't do a study where you just evaluate the best patients. You should do a study where you have all type of bone quality. I mean, you know better than me that you have more failures in bone quality 1 that is very hard, or 4 that is very soft. And this study eliminated these patients. So the patient which could have been more beneficial because they are the one having more problem, then they might not be included, and this could have been altered the results. Now, if you tell me I'm a fast surgeon, I know what to do, I treat simple case, I don't give antibiotics, for me it's fine. But if you are not a fast surgeon, if you mess up all the surgery, if your implants fall down and then you collect it while the nurse is fainting because it's the first time that she sees some blood, well, in that scenario, maybe you should provide antibiotics. So it depends also on your speed and skills and on the number of patients that you treat.
Yeah, I got it. I think it's a very important point to notice, because as you mentioned, with the high level of studies like systematic reviews, we can conclude in our best level, and why not follow the available reliable literature and make our practice and our patients everything more accurate, more predictable. Again, I want to first thank you so much.
May I add only one thing? Can I just add one thing on systematic review?
Yes, sure.
Systematic review are evaluating the study that are there. They are not making the study better. So if the quality of the study is poor, even if you do a good systematic review, the results are not good. You understand? So only if you do a systematic review properly of good study, you close to the truth. Because if you would do a good systematic review of bad studies, you are not close to the truth. So you need to interpret this and understand that the quality of the studies of the original piece is the most important part.
So it's very important when we read systematic reviews to go in depth and also evaluate ourselves, as you said, just not reading it, but the decision is ours. So we should go and see what was the value of those studies included in that systematic review. You're right. I think it's a very important point that we should notice. Marco, I truly want to thank you for your time, and I really recommend you all to go to Marco Esposito's Facebook page. You can find 2 issues of this new journal of clinical trials by him. It's free for downloading, and you can get more information. The link, everything is available on his Facebook page. And it really was going in and read those articles, and we're looking forward for more and more and more reliable articles from your side, Marco. Thank you again for joining me, and thank you everyone for joining us in the webinar.